Welcome. This is a presentation on advanced treatments for female urinary incontinence. You're probably watching this presentation because you've already tried things at home, maybe even medications, for urinary leakage. This presentation will go through treatments that your doctors in the Department of Urology can offer to improve incontinence and help your overall quality of life. The goals of this presentation are to review normal bladder function, and then to understand the different types of incontinence and identify which type you have. The different types of incontinence are stress urinary incontinence, overactive bladder with incontinence, or both of the above, and we call that mixed incontinence. It's important to know the difference because different treatments are applied depending on which type you have. And then we'll go through the different medical and surgical treatments for incontinence and examples of how they help. This is a diagram of normal urinary tract anatomy. In this diagram, you can see the kidneys, ureters, bladder, and urethra labeled on the right-hand side of the slide. The kidneys make urine, which then travel down the tiny tubes called ureters into your bladder. The bladder expands like a balloon and stores urine while you're doing all the things you would normally do during the day. The bladder should expand as a reservoir and hold urine quietly until it's full, when it sends a message to your brain that you need to use the restroom. While the bladder is filling, a sphincter muscle closes the urethra so urine doesn't leak out of the bladder until you're ready to use the restroom. Abnormal bladder function happens when the bladder doesn't fill and hold urine quietly, or when the sphincter that closes the urine isn't strong enough to keep urine in. When the bladder doesn't fill and hold urine quietly, we refer to it as overactive bladder. This is characterized by urinary urgency and frequency, and also leakage that occurs with urges when you can't make it to the restroom in time. When there's leakage of urine in between urinations with sudden movements such as cough and sneeze, we call that stress urinary incontinence. Finally, incontinence can happen when the bladder does not empty well. If your bladder is filled with urine, it's more likely to leak with cough and sneeze, or when you've waited too long to use the restroom. This can happen with older patients who have bladder prolapse, which is called a cystocele. It can also happen for patients who have nerve impairments to the bladder. As a review, the types of incontinence are overactive bladder, stress incontinence, and mixed urinary incontinence. Now let's talk about overactive bladder. What is overactive bladder? Overactive bladder is caused by abnormal bladder contractions. Hyperactive bladder muscle causes the bladder to contract even when you're not ready to use the restroom. Those abnormal bladder contractions cause the symptoms of urinary frequency, which is needing to use the restroom more frequently than every 4 hours, urinary urgency, which is an urgent need to use the restroom and rush to go to the bathroom, and urge incontinence, which is when you can't hold your urine and have an accident on your way to the restroom. What causes overactive bladder? The actual cause of overactive bladder muscle contractions is unknown. It's possibly due to a muscle problem, a nerve problem, or both of those. There are health conditions that cause the symptoms of overactive bladder, such as hypertension, diabetes, obesity, increased intra-abdominal pressure, constipation, and vaginal dryness after menopause. Other things that cause overactive bladder symptoms are bladder irritants like caffeine, chocolate, spicy foods, artificial sweeteners, and acidic juices, and bad behaviors or habits like holding your urine for too long when you may be too busy to use the restroom. There are various treatments for overactive bladder. Some of them you may have already tried. We usually like to start with non-invasive treatments like behavioral modification, physical therapy, and/or medications. Examples of medications for overactive bladder are Ditropan and Detrol. Non-invasive treatments don't always help for severe overactive bladder symptoms, especially urgency with urge incontinence. Not too long ago, medications were the only option. More recently, procedures have been developed which help immensely for those symptoms. We have 3 procedures available for overactive bladder. They include Sacral Neuromodulation, or InterStim, Posterior Tibial Nerve Stimulation, and bladder Botox injections. Here's another way to conceptualize treatments for overactive bladder. When we work to help our patients with these symptoms, we start with the most conservative therapies. Examples of those would be avoiding foods and beverages that irritate your bladder and managing constipation. Many times these help fine and patients don't even need to take medications or try procedures. But if those things don't help, we have other things that can, and we like to work in a stepwise fashion from conservative therapies to more advanced therapies. For the rest of this presentation on overactive bladder, I'm going to work my way from the top down, starting with our more conservative treatments like physical therapy and acupuncture, working through medications, and then talking about our advanced therapies like Botox for the bladder, sacral neuromodulation, and posterior tibial nerve stimulation. It's important to note here that there are no cures for overactive bladder symptoms. The goals of our therapy, which are the treatments mentioned previously, are to lessen frequency of bothersome symptoms, lessen the intensity of symptoms, lessen the volume of urine lost, and improve your overall quality of life. Let's start with talking about conservative therapies. These are things you can do at home on your own, like avoid bladder irritants, manage constipation, treat vaginal dryness, and stay well hydrated. A good place to start with conservative measures is dietary treatments for overactive bladder. The first thing to do is avoid bladder irritants. Bladder irritants are foods and beverages that irritate the lining of the bladder and cause urinary frequency, urgency, and even urge incontinence. Examples of bladder irritants are any beverage with caffeine, such as coffee, tea, and sodas. Chocolate also contains caffeine and is known to be a bladder irritant. Alcoholic beverages irritate the bladder. Acidic and spicy foods are known to irritate the bladder as well. This includes juices like orange juice and grapefruit juice. There may be other identifiable bladder irritants that you've noticed on your own that can cause these symptoms. You may want to use a food diary to identify the culprits. It's important to stay well hydrated. Concentrated urine from dehydration is a bladder irritant in and of itself. You may be tempted to avoid drinking water because you always feel like you have to use the restroom. But if you don't keep your urine dilute with water, it will only make things worse. Other things that will really help your symptoms are below. It's very important to manage constipation if this is a problem for you. See your urologist or your primary doctor about suggestions for high-fiber diet and supplements. Also, treat vaginal dryness. Vaginal dryness and pH changes in the vagina after menopause are very common. For postmenopausal women, we often recommend a cream which contains estradiol. This is a topical cream that's placed in the vagina. It does not go into your body like a hormone supplement that you may have taken as a pill or a patch. There are several different ways to use this. It can be used as a cream, suppository, or a ring. This helps overactive bladder because it adjusts the pH in the vagina and prevents the dryness which can irritate the bladder and cause the symptoms of frequency, urgency, and urge incontinence. If conservative measures aren't working completely to help your symptoms, you may consider some other treatments, such as physical therapy or even acupuncture. Physical therapy for the bladder works extraordinarily well for overactive bladder symptoms. This is more than just Kegels. This is a one-on-one therapy session to learn exercises with a licensed specialist who knows about pelvic floor physical therapy for your overactive bladder symptoms. It's very effective for the motivated patient, and we have excellent therapists at Kaiser Permanente. Another option is acupuncture for the bladder. This is also done with a licensed professional, and there are excellent specialists in our area. Acupuncture really helps for overactive bladder. It's not a covered service at Kaiser Permanente, but your urologist will be happy to refer you to someone in the area. If the above conservative therapies have not helped the way you want them to, and physical therapy or acupuncture are not working or not options for you, you may consider taking a medication for overactive bladder. The following are medications for overactive bladder. The most common treatment for overactive bladder is medication. It makes sense that a tablet you take once or twice a day would be relatively convenient and a nice place to start after those other conservative measures have failed. For a long time, we only had one medication available, and that was oxybutynin. It's also known as ditropan. It's less expensive because it's a generic, but it's not as convenient because you have to take it 2 to 3 times a day. It also has a higher rate of side effects than some of the newer, more designer drugs. More recently, a number of name brand medications have come to the market. They have a more convenient once daily dosing and fewer side effects. We also have a relatively new patch that can be used for overactive bladder, and you may have seen that this is available over the counter. The Oxytrol patch has the same efficacy as the medications. Some people just like the convenience of using a patch twice a week. Medications work pretty well, and they are convenient, but they do have side effects, just like any medication. The most common side effects of these medications for overactive bladder are dry mucous membranes and constipation. The dry mucous membranes result in dry mouth and dry eyes, and also dry nose. Patients can minimize this with Biotene, which is a mouthwash for dry mouth, chewing gum, or using sugarless candy. If constipation occurs, you may increase your dietary fiber and water consumption. Less often, patients have complained of blurry vision and also memory loss or confusion in elderly patients at high risk. Some patients also have indigestion or heartburn. You can't take these medicines if you have closed-angle glaucoma, GI motility disorder, or dementia. For patients who have already tried medications that don't work, we now have advanced therapies for overactive bladder. These therapies work very well and help many patients with their symptoms. Like medications, they have their pluses and minuses, and there are risks and benefits to each procedure. We'll start with bladder Botox injections. Botox is being used in all aspects of medicine. Botox is injected directly into muscle to relax it. This can help everything from crow's feet around your eyes, to muscle spasms in your legs, to migraine headaches. In urology, we use Botox to relax the muscle of the bladder. This is an office procedure. There's no prep, medications, or recovery needed. During the procedure, a small scope is put into your bladder, and a needle is put through that scope to inject the Botox directly into the muscle that surrounds your bladder. Depending on your dose of Botox, you could get anywhere from 10 to 20 small injections. The effects of the Botox take place in about 4 to 5 days. And you have benefit for about 6 to 9 months. That means that anywhere from 6 to 9 months, you won't need any medications or other treatments for your overactive bladder symptoms. The risks of the procedure are a urinary tract infection from the injections, blood in your urine for 1 to 2 days, and then most importantly, a risk of urinary retention. Because the Botox is relaxing your bladder, there is a risk that your bladder could become so relaxed that you can't urinate at all. In a sense, what's happening is the opposite of your problem. Instead of going too much, you can't urinate at all. This can happen in about 7% of patients after Botox injections. It happens more commonly in patients who have neurologic problems such as multiple sclerosis or spinal cord injury. So for the most part, 93% of patients do just fine and have no problems. But it's important to remember that this could occur. If it does, you'll need to use a small catheter to empty your bladder, and we'll teach you how to do that in urology. To summarize, the most unwanted side effect of bladder Botox injections is urinary retention. This happens in about 7% of patients. For those patients with neurogenic bladder, such as patients with multiple sclerosis or spinal cord injury, it happens about 25% of the time. Remember, this is a temporary side effect. It's not permanent. Your bladder function will return in 4 to 6 weeks if this side effect occurs. Next, I'm going to talk about Sacral Neuromodulation. It's also known as inner stim and sometimes referred to as the pacemaker of the bladder. Sacral Neuromodulation is a type of pacemaker implant. It's similar to these pacemaker implants, which are used for a multitude of diseases throughout the body. The sacral neuromodulation pacemaker implant works by generating electrical impulses to nerves that moderate bladder function. The indications for its use are all aspects of overactive bladder: urinary frequency, urgency, and urge incontinence. It can also be used for non-obstructive urinary retention, which is the inability to empty your bladder. Because InterStim placement is a surgical procedure and does require a commitment, you can test it in the office before you decide to have it implanted. The test procedure is called PNE, or Percutaneous Nerve Evaluation. It's done in the office, there's no anesthesia or medications needed, and about 70% of patients see benefit from the test and decide to have the device implanted. If you see good results from the test and decide to go on to implantation, this is the pacemaker-like device that will be implanted in the fleshy part of your upper buttocks. Implant in the operating room is an outpatient procedure. It takes about 1 hour. There's no general anesthesia necessary. The anesthesiologist will give you some medications to help you feel relaxed while you lie on your stomach during the procedure. It will be very similar to the procedure you had in the office. The new lead and pacemaker are implanted. It's important to understand the risks of this procedure. With any surgical procedure, there are risks of bleeding and infection. The risk of bleeding is low with InterStim placement. Infection can occur, and for this reason, we give you antibiotics before and during the case, and we also send you home with a week of antibiotics to take. There's also a risk that the device won't work for your symptoms, even though it worked during the testing period. There can be pain at the generator site, and there can also be transient abnormal sensations that occur. For these reasons, your device may need to be removed or revised in the operating room. The last procedure in this section of the presentation is posterior tibial nerve stimulation. Posterior tibial nerve stimulation is another type of neuromodulation. It's a way of modulating nerves that eventually connect to your bladder and help your overactive bladder symptoms. With this procedure, a fine accupuncture-like needle is inserted above the ankle into a nerve. You undergo 30-minute treatment sessions. There's 1 session per week for 10 to 12 weeks. Low voltage electrical stimulation occurs. It's not painful. This may require long-term repeat treatments every 3 to 4 weeks to maintain benefits. Here at Kaiser Permanente Santa Rosa, we've developed an electrode patch to avoid the needle. We can even show you how to use this at home. A small stimulator will come in the mail, and a nurse in our office will show you how to use this at home. If you use it for 10 to 12 weeks, once a day for 30 minutes, you may see lasting results of your overactive bladder symptoms. Looking over the original algorithm for overactive bladder treatment, there are quite a few options to choose from. Given your preferences and what you may have already tried, there's probably something that can work for you moving forward. Let your urologist know if you have any questions about any of the options discussed here. The other type of incontinence is stress urinary incontinence. This is when the small sphincter that holds your bladder closed has weakened due to age or childbirth. The following slides will discuss treatments for stress incontinence. What is stress incontinence? This is a sudden involuntary loss of urine associated with increase in an intra-abdominal pressure. That means that when you bear down for whatever reason on your bladder, urine leaks out. This is caused by cough, sneeze, laugh, and exercise. The sphincter of the bladder is failing you when you need it most. There are no medications that can help stress incontinence. The problem is a weak muscle at the opening of your bladder that's not holding urine when you need it to. When we talk about treatments for stress incontinence, we divide them into non-invasive treatments and invasive treatments. Everything is aimed at giving support to that little muscle. Our non-invasive treatment is pelvic floor physical therapy. Invasive treatments include urethral bulking agents and midurethral sling surgeries. This is the treatment algorithm for stress urinary incontinence. It includes non-invasive therapy, which is pelvic floor physical therapy. And if that fails or is not appealing to you, then you can move on to advanced therapy. We have office-based treatment, which is urethral bulking agents, or surgery, which is urethral sling surgeries. I spoke about pelvic floor physical therapy earlier in this presentation in regard to overactive bladder. The great thing about pelvic floor physical therapy is it's the only thing that we offer that works for both overactive bladder and stress urinary incontinence. As a review, these are exercises that you do one-on-one with a licensed specialist. They're more than just Kegel exercises. They're very effective for the motivated patient, and as I mentioned, work for both stress and urge incontinence. It's a great place to start if you have both. For procedures that we do, I'll start with an explanation of the urethral bulking. Urethral bulking procedures are similar to those fillers that are used in plastic surgery to plump up lips and fill in lines. In urology, we use bulking agents to plump up the urethra so leakage is less likely from the opening. This is an office procedure. There's no prep, medications, or recovery needed. During the procedure, a small needle is placed through a scope into the urethra. The filler is injected at the opening of the bladder, as you can see in this diagram. The filler is the white lump at the opening of the bladder, and you can see when it's injected, it plumps up the opening so leakage is less likely to occur. Urethral bulking works very well to stop leakage, and it starts right away. Occasionally, patients may need to return shortly after their first injection to get a little more bulking injected if they're not seeing complete results of their stress incontinence. But like the products used in plastic surgery, the time length of effect is limited. These products wear off, and patients generally return around 5 to 6 months to get re-injected. Some patients see longer results in between injections. It's important to remember that this doesn't last very long, and it might be something that you have to return for repeatedly. The risks of urethral bulking are minimal. There is discomfort during the procedure, and that's because an injection is being made into a delicate area. The procedure itself lasts about 5 minutes, and there are 2 injections, one on each side of the urethra. There's also a risk that your stress incontinence could persist. This could happen because the bulking agent isn't working properly for you. There's also a risk of light bleeding in the urine that can last about a day. Many people have stinging and burning with urination that lasts about 1 to 2 days. Very rarely, patients have difficulty emptying the bladder. This is temporary and will go away and doesn't occur very often. If it does, you may need to learn how to pass a small catheter to empty your bladder for a day or 2. The most successful and durable treatment that we have for stress incontinence is urethral sling surgery. In this diagram here, you can see that the sling is positioned around the opening of the bladder. It's right at the urethra, which is where urine can leak during stress maneuvers like cough, sneeze, laugh, and exercise. On the left-hand side, you see that the sling is very small. It's made of a sterile, inert polypropylene mesh. It's about the size of a piece of tape that you might wrap a package with, and for this reason, it's often been referred to as a tape. Some people also refer to it as a hammock. Urethral sling surgery is the gold standard of care for stress incontinence. There are two main surgeries that we do: a transvaginal tape, or TVT, and a transobturator tape sling procedure called TOT. The materials are the same and the approach is very similar. The TVT moves upward from the urethra, providing support from above the bladder, and the TOT moves outward from the urethra, providing support from the sides. Both are equally effective, and most of the time the choice to use one or the other is physician preference. The overall success rate of these products is 86.9%. Here is another diagram of the sling procedure with more detail. I've drawn it like a cartoon to show exactly what's done during the surgery. During this procedure, a small incision is made in the vagina. The incision is about 2 to 3 inches long. The small tape is placed through the vagina and around the bladder neck so that it's supported from the bottom. With a TVT, 2 tiny incisions are made on your belly, just above the bladder. With the TOT, 2 tiny incisions are made in the groin creases between your labia and your inner thigh. All in all, the procedure takes about 30 minutes. You'll be in the operating room for about an hour. Recovery is about 45 minutes to an hour, and you go home the same day. As mentioned, this is outpatient surgery, and you go home after a short recovery in the recovery room. You may choose what kind of anesthesia you like, spinal or general anesthesia. It's a minimally invasive surgery. There's 1 small vaginal incision and 2 tiny skin incisions. The sling is composed of a permanent synthetic mesh that becomes incorporated into your body during postoperative recuperation. Because this is surgery, there are more risks associated than some of our minimally invasive procedures we do in the office. The urethral sling surgery has some operative risks. There's always risk of injury to the bladder, urethra, surrounding blood vessels, or even intestines, but this is very rare. Long-term risks are about 10%. There's a risk that you might still have incontinence after the procedure. You may develop new or worsening urinary urgency or frequency. You may have difficulty emptying your bladder or even have urinary retention. There's a risk of erosion of the small tape into your urethra or your bladder. And there may be need for removal of the sling for other reasons. The last 2 on this list, mesh erosion and need for removal of the sling, are very rare, 1% or less. During recovery after urethral sling surgery, you'll be asked to limit your activity so that the sling heals into place appropriately. The recovery process requires that you don't lift or strain for 4 weeks after surgery. You'll be asked not to engage in any vigorous exercise or vaginal intercourse. It's very important that you don't get the incision in your vagina wet. It needs to heal appropriately. So you'll be asked not to swim, use a bathtub, or go in a hot tub for at least 2 weeks after surgery. Most women can resume work within 1 week. So when we look back over our options for stress urinary incontinence, you can see there aren't as many as we have for urge urinary incontinence. However, these 3 options work very well, and given some proper counseling from your urologist, you should be able to find one that works for you. Overall, there are many urinary incontinence treatments available. Careful evaluation to determine your type of incontinence is necessary. Consideration of risks and benefits of each treatment will guide your decision. Ask your urologist for more information. You can always email us through kp.org or call the urology office at 393-4064. Thank you.